Thank you for joining us for a session focused on advances in understanding and treatment of major depressive disorder. Indeed, our particular focus will be designing collective and collaborative care in treatment of major depressive disorder, and also listening to our patients' cues and detecting some information that may help guide our treatment. So these are my faculty disclosures. Further disclosures related to FDA approval and CME matters are learning objectives. And on we go. What are some of the challenges in treating major depressive disorder? For one, it is not a single condition. So both clinically and biologically, major depressive disorder is heterogeneous. And therefore, there will be no one-size-fits-all treatment for all our patients experiencing major depressive disorder. Unfortunately, our descriptive nomenclature does not allow us to deduce what will be the best treatment for an individual patient suffering from MDD. So is there some guidance? Furthermore, we have to be aware that mood disorders are truly mind-body disorders, and therefore they have correlates in the body that are associated with endocrine, immune, and autonomic function disturbances. Finally, the best guarantee that our patients will have good long-term outcomes is if we can help them achieve remission. So let us review some of the shortcomings of the current treatments of major depressive disorder. In order to have common reference base, it is a good idea just to redefine some of the terms that will be utilized in the course of this presentation. So first, what is response? Response normally designates 50% reduction in depression score on a standardized scale. So the patient is doing better, but not all the way well, not in remission. What would constitute remission? Remission is commonly defined as a score of 10 or 12 or below on Montgomery-Åsberg Depression Rating Scale, or score 7 or less on Hamilton Depression Rating Scale. But beyond that, true remission would mean that our patient is symptom-free. True remission would mean that our patient returns to a prior level of functioning. So this is functional remission. If our patient has retained remission that has been sustained over an extended period of time, so more than 2 months, it is now viewed as recovery. Why would this be relevant? Because if our patient achieves remission, but relapses within 2 months of achieving remission, this is termed a relapse. It is the same episode that the patient originally suffered from. On the other hand, if they sustained the remission over the course of 2 months, and therefore they are in recovery, and have, again, emergence of depressive symptomatology, this is no longer counted as the same episode. This is now a new episode, and this new episode is labeled as recurrence. So I think this will help us have common terminology as we proceed with this presentation. So indeed, what is the scope of suffering in individuals who have major depressive disorder? Well, number one, in terms of disability-adjusted life years, depressive disorder is by far on the top spot amongst psychiatric conditions. I can even say neuropsychiatric conditions. As a matter of fact, in women, major depressive disorder is number one source of disability worldwide. It is the most common mental health disorder in the United States, with the prevalence exceeding 16%. Roughly translating into 1 in 5 citizens of US will experience a major depressive episode at some point during their lifetime. It is not only prevalent, it is associated with significant loss of quality of life and function, and the cost associated with a major depressive disorder, be it a direct cost, treatment of major depressive disorder, hospitalization, medication costs, but also loss in productivity, it all exceeds $100 billion. So where are we now? As we observe the outcome of STAR*D, a large government-sponsored systematic trial of antidepressants, we see that approximately 40% of the patients initially treated with an SSRI for 12 weeks still suffer from moderate, severe, or very severe symptoms. So again, 40% with moderate or worse symptoms of major depression after 12 weeks, 3 months of treatment with an SSRI. Indeed, we cannot be happy with that outcome. More not so good news. If we look at next steps in STAR*D, so this is where an SSRI is replaced with another SSRI or norepinephrine dopamine reuptake inhibiting agent, or SNRI. What happens as we continue with different combinations of antidepressants? By the way, these are all antidepressants that modulate monoamines. Here's what we're finding. Step 2 is associated with lower remission rate. So first step, about 37%. Now we're down to 30%. But then there is a steep drop-off. And step 3 and 4, as we go to more aggressive combination of antidepressants, we see that we're facing diminishing returns. Our patients' remission rates are 13.7 and 13%, so substantially lower, less than half of what they were in step 2. To make matters even more concerning, discontinuation rate due to adverse reaction keeps on rising. So the more exotic, so to say, the more complex combinations of antidepressants, they do not result in better remission rates. What they result in is in greater discontinuation rates. And yet another study coming from STAR*D, we're trying to see if our patients are responding but not remitting. What are some of the residual symptoms that are there? So although they are technically responding, between 65 and 80% of our patients are still exhibiting mid-nocturnal insomnia. They're waking up through the night. They have sad mood. They have difficulty with cognition, making decisions, remaining focused on their work, and their energy is inadequate. So these tend to be the most troubling, the most staunch residual symptoms of major depressive disorder. Is there really, from the functional perspective, a difference between a responder and a remitter? So this is a study that attempted to answer that question. And what was noted is, although the differences in terms of the scores on clinical scales may be discrete, they're very meaningful when it comes to functioning. So looking at short form scale that reflects functioning in terms of physical functioning, functioning in one's role, general health, bodily pain, we're finding out that there's this significant difference between remitters and responders. In addition to that, we're finding that when it comes to somatic symptoms, patients who are not in remission have considerably more somatic complaints. And of course, all these lead to more numerous physician appointment. And in terms of their functioning at work, we see a phenomenon that reflects so-called presenteeism. People are going to work, but on the other hand, their productivity is substantially reduced. So there is significant meaning that reflects the difference between remission and response. How exactly can we ascertain how our patients are responding to treatment? Where there are several very useful tools that can be used to evaluate our patients' progress. Some of them have multiple roles, in a sense that they can be used as screening tools, but also diagnostic tools in monitoring treatment outcomes. A few that are most frequently used in clinical practice and in some of the studies are PHQ-9, which is patient health questionnaire, 9-item version, quick inventory of depressive symptoms, self-rated version or quiz, and back to depression inventory. This is now second version of this instrument. It can be used both to screen, to identify if our patients have major depressive disorder, but also monitor their progress. If we want to use instruments that provide more diagnostic information, fine-grained diagnostic information, structured clinical interview, this is designed for DSM-5, it's a revised version, is available, or international neuropsychiatric interview, also known as MINI. Those are more definitive diagnostic tools. So, is there some reflection of severity of depression used with one of these commonly utilized tools such as PHQ-9 and patient functioning? We said that patient functioning is something that is of cardinal importance in terms of evaluating treatment outcomes. And we indeed are finding that on one hand, we can look at the scale where patients on PHQ-9 who have score less than 5 are believed to be asymptomatic. 5 to 9 reflects mild depression, subclinical depression, and scores 10 to 14, this is now clinical depression, moderate, 15 to 19, moderately severe, and above 20, severe depression. But we also see that these scores directly reflect mean disability days, symptom-related difficulty in functioning and quality of life, and are even reflected in the number of physician visits. So again, these are not just numbers, these are numbers that reflect real life struggles of our patients. Of course, before we make diagnosis of major depressive disorder, we have an important rule out. So just to remind you, about 2/3 of the individuals who suffer from bipolar disorder are initially misdiagnosed as having MDD. So it is very important to differentiate individuals who have major depressive episodes associated with bipolar versus the ones who have major depressive episodes associated with MDD. Treatment course, of course, is quite different. What are some of those indicators of bipolarity? Typically, bipolar disorder has an earlier onset. So if our patient has first depressive episode in teenage years, odds are roughly 2 to 1 that it is going to become bipolar disorder. Bipolar episodes tend to have greater frequency than episodes associated with major depressive disorder. And these patients will have very different pattern of responding to antidepressants. So antidepressant use is very often associated either with only partial improvement or temporary improvement. Patients are doing a little bit better for a period of time before their symptoms worsen again. On the other hand, use of antidepressants can be associated with misadventures. These patients can have disturbance in their sleep, increasing anxiety, or mixed symptomatology. Probably less frequent, but very alarming consequence of using antidepressants in bipolar patients is so-called syndromal switch. So patients will develop full-blown hypomanic or manic episodes in response to antidepressant treatment. So this is something that we need to listen to carefully when evaluating our patients. Individuals who suffer from major depressive episodes associated with bipolar disorder also have greater risk of substance use. They have greater risk of attempting suicide. They have a greater likelihood of exhibiting anxiety symptoms and eating disorders. Also, they have a slightly different seasonal pattern in that both MDD and bipolar patients tend to have more depressive episodes in the late fall and early winter. But in addition to that, patients suffering from bipolar disorder have a secondary peak in depression, which is in the midsummer months. So if you're a depressed patient repeatedly comes to your office complaining of depressive symptomatology in the middle of the summer, consider that this person may be suffering from bipolar disorder. Bipolar disorder is also associated with more frequent history of bipolar in the family members. So if a family member has bipolar disorder, odds are 2 to 3-fold greater that our patient is also suffering from bipolar disorder. On the other hand, if this is a first-degree relative, the risk of bipolar disorder in our patient is about 5 to 7 times greater. Presence of mixed symptomatology, especially 3 or more mixed symptoms, also indicates greater likelihood that our patient may be suffering from bipolar disorder. So let us look at some practical takeaways. Having a response but not remission still leaves the blinking yellow light behind. It's a warning. It is an indicator that our patient is more likely to relapse and have recurrence. It is an indicator that our patient's functioning is suboptimal. And one of the useful ways of differentiating individuals who are responders versus remitters, and also something that can help us monitor treatment outcomes, is utilization of scales. And I would very much encourage you to utilize these scales. We have mentioned several that can be used as screening tools, diagnostics tools, but also to monitor treatment outcomes. And mood disorder questionnaire, which can be utilized to help you differentiate major depressive disorder and bipolar disorder in our patients. So let us now look at some of the factors that are associated with reduced response and increased relapse rates in patients suffering from major depressive disorder. So in order to help us work through this information, we have a case vignette. Lucy is a 32-year-old married female. She has been referred by her primary care physician for treatment of depression, which started 6 months ago. She was initially treated with an appropriate dose of an SSRI. Well, a couple of things. She's 32. Episode started 6 months ago, so episode started in the 30s. Now, big question is this the first episode? If the episode started mid-20s or later, the odds are that indeed it is associated with MDD. So true start of depression in the 30s is 5 times more associated with major depressive disorder versus bipolar disorder. She reports feeling sad and tired most of the days. So these are the more common residual symptoms. She has inadequate energy, she is sad, and in addition to that, she is waking up often during the night. So she even has that third common residual symptom, mid-nocturnal insomnia. Anhedonia is not easy to address. And Lucy has loss of interest for work and hobbies and has been socially withdrawn. Question is, can antidepressants help with tendency to socially isolate? Lucy has to make herself go to work, so there is some evidence on functional impairment. She and her husband have been having ongoing marital problems in the past. Problems functioning in the sphere of relationships. And she's also concerned about weight gain, possibly related to her medication use. But also keep in mind that weight gain is more pronounced in patients who are not appropriately responding to antidepressants. Following SSRI treatment, her anxiety has improved, but she still has some residual irritability. So might this guide her treatment? Is this important information? Well, first of all, what are some of the factors that have association with treatment resistance? So what are some demographic characteristics of patients who are not likely to respond as well to antidepressant treatments? Well, some of the major factors include having recurrent form of major depressive disorder. So patients who have had repeated episodes, especially if they have melancholy features, if they've had multiple hospitalization, if they've had non-response to their first treatment, all these are indicators that we may be subsequently dealing with resistance. Resistant patients tend to have more severe form of major depressive disorder and very often have comorbid personality disorders and substance abuse. Early onset of depression, so onset before age 18, anxiety disorders are also associated with greater risk of non-response. This is particularly interesting since we're now finding out that patients who have major depressive disorder are also genetically heterogeneous. So this is thanks to large-scale genome-wide association studies. And we're finding that many of our patients suffering from MDD may have admix of bipolar risk genes. They can be added up and it will translate into something that is called polygenic score. So patients who have higher bipolar polygenic score, meaning higher genetic loading towards bipolar illness, although they do not meet criteria for bipolar, these are MDD patients, tend to have earlier onset of disease, tend to have more anxiety, tend to have more ADHD-like symptoms, tend to have heightened risk of suicide, tend to have a greater propensity towards substance use. So many of these characteristics that are associated with non-response to antidepressant are possibly reflection of bipolar diathesis in our MDD patients. On one hand, we have to be concerned about the efficacy of treatment. But on the other hand, we also have to be concerned about how well will the treatment be tolerated. And in this relatively large survey, including 350 patients, we're finding that a considerable proportion of patients are finding that it is extremely difficult to live with some of the adverse reactions. Number one, change in weight gain. Patients are very dissatisfied with this outcome. On the second place are sexual difficulties associated with antidepressant use. Also, towards the top of the list, feeling tired during the day, having no energy, and having sleep disturbance. These are all very relevant indicators because they may translate in non-adherence. As a matter of fact, 1 in 5 patients in this survey was not taking their medicine regularly. And if we look at the reasons why they're not taking medicine, they again have to do predictably with changes in weight, sexual side effects, or forgetting to take their medication, especially if the regimen is complex. We do have this tendency because, fortunately or unfortunately, mainstay of psychiatric care of major depressive disorder has been focused on psychopharmacologic treatment. But this is a very important time to consider other factors. The fact that patient is not responding very well to medicine may not have to do with the choice of medicine. It may have to do with other factors in their life. So in this particular study, it is a fair-sized study, included 171 patients. Researchers examined satisfaction with primary relationship. It was evaluated using a marital adjustment scale, and it was categorical distribution. Individuals who had score above 2.36, this was the median score, were labeled as having dyadic discord. Patients who had lower score did not have dyadic discord. Did it influence their response to treatment? And indeed, having relationship discord reduces remission rates in half, both to pharmacologic intervention, in this case Lurasidone, but also to cognitive behavioral intervention. So 50% reduction in remission rate, indicating that it's not always about medicine. Sometimes it's about other important factors in our patient's life. And something that is also a takeaway message from this particular study is combination of medication and cognitive behavioral therapy was associated with the best possible outcome. So if indeed there are primary relationship issues, medication alone or psychotherapy alone may not nearly be as effective as combining these treatment modalities. Another study points to something that is very important, and it is a study that is examining the relationship between childhood maltreatment and response to treatment. And what we're indeed finding out that presence of childhood maltreatment will substantially influence outcome to antidepressant therapies. So they're 40% likely to have a worse outcome, and it more than doubles the rate of recurrent and persistent depressive disorder. So yet another focus. If our patient's not doing with medicine, is there dyadic discord? What are primary relationships like? And could we be missing that our patient may have suffered childhood maltreatment, which again would have a negative impact on treatment outcomes? And again, a scenario where combination of medication and psychotherapy is much more successful than either modality alone. Yet another factor, BMI. So does our patient's weight in any way influence treatment outcome? This is a fair-sized study that was conducted in Germany. Patients were treated with a variety of antidepressants for 5 weeks. They were categorized to individuals who have normal weight, so equal or less BMI 25, between 25 and 30, overweight, and BMI above 30, so obese. What was the impact on treatment? Average patient that had BMI equal or less than 25. So normal, what is considered normal and healthy weight, they were responders. On the other hand, patients who had BMI above 30, so were obese, on average, they were non-responders. All these patients were hospitalized, so treatment adherence is less likely to be a factor. So again, indication that having higher BMI may have a negative impact on treatment outcome with antidepressants. And additional study looking at BMI, but also looking at peripheral inflammatory signaling. There's a very simple way of measuring this by measuring C-reactive protein, especially high-sensitivity C-reactive protein. And what we're finding out is if we correct for BMI, levels of CRP or C-reactive protein are significant differentiator. In this scenario, healthy volunteers and treatment-responsive patients seem to have similar inflammatory indicators. On the other hand, if they had greater peripheral inflammation, these patients tended to be treatment-resistant. They tended to be similar to untreated patients. So peripheral inflammation may also reflect treatment resistance, and there are some clinical manifestations that would indicate that we need to further look into this matter. So if our patients are suffering from psychomotor retardation or agitation, if they have middle insomnia, if they have state anxiety, it is likely to be associated with greater peripheral inflammatory indicators. So again, if they're not responding to antidepressants, it may be that our choice of antidepressant was suboptimal, but it also may mean that our patient has difficulties in their primary relationships. It may mean that they're exposed to chronic stress. It may mean that they have higher BMI or higher peripheral inflammatory signaling, or it may mean that they have experienced early life adversity, that they've been maltreated. This is important because it does have treatment implications. So here are our practical takeaways. Troubled primary relationships, early life adversity, chronic medical conditions, especially associated with inflammation, chronic stress, delay in treatment, substance abuse, personality disorders, all may have substantial impact on response to antidepressants. So it's not always about medicines. So now let us look at something that is a burning clinical issue. When do we augment, when do we combine, and when do we switch antidepressants if things are not going well? So here we have delineated some of the treatment strategies that are likely to give us an early, speedier response in treatment of MDD. And as we see, ketamine and esketamine, which is actually approved for treatment of major depressive disorder, ECT, electroconvulsive treatment, and transcranial magnetic stimulations are treatments that can deliver more speedy response to medication treatment of depression. On the other hand, how about efficacy of various interventions for patients who have failed to respond to antidepressants? Here we see a little bit different picture. TMS, so rTMS, is still an effective strategy. It has about 8-fold a likelihood of providing symptomatic relief to patients who have not responded to an antidepressant. But in addition to that, there are a number of agents that have been approved as adjunctive treatments to MDD, and they are in second-generation antipsychotic category that are helpful. So a positive data exists for brexpiprazole, aripiprazole, and higher dose of quetiapine. These are all strategies that might substantially increase the likelihood that our patients who have failed an antidepressant will now do well. Furthermore, is it better to switch or augment? And this is now a meta-analysis that has looked at switching to a new antidepressant after initial non-response to treatment. Data may be really surprising to you. So if we look at two types of measure, one is the difference before and after. What we're finding out, if we continue the agent to which our patient has had suboptimal response, they're still better off than if they're switched. And in terms of remission, there is no difference. So in terms of remission rate after our patient has had suboptimal response, if our patients continue with that treatment that was only partially successful, they will do statistically just as well as if they are switched. So it seems that if we have some benefit, even suboptimal, it does not necessarily lead to need to switch an agent. We need to start thinking about combination and augmentation. So this is directly from STAR-D. Patients have had suboptimal response to an SSRI. There are two strategies, augment or switch. And we're seeing that augmentation is a more successful strategy than switching. Some further proof, again from STAR-D, this is now step 2. Patients could be switched from an SSRI to bupropion, a norepinephrine dopamine reuptake inhibiting agent, to another SSRI, sertraline, or to an SNRI, venlafaxine XR. And as we can see, whether we stayed with the same class or switched to a different class of agent, the outcomes are statistically similar. So switching to one versus another category didn't bring on a whole lot of difference. On the other hand, we also see outcomes of a large European study. This is group for the study of resistant depression. And we're looking at response and remission rates if patients indeed stayed within the same antidepressant class or switched to a different antidepressant class. And unfortunately, disappointing finding is that patients who were not switched, although they had suboptimal response, tended to do numerically better than the patients who were switched. Altogether indicating if we have some response, keep it and consider augmentation and combination versus switching. Switching should be reserved to patients who have had no response. So less than 25% improvement in 2 weeks, those would be the candidates to potentially switch the medication. Then there is additional evidence suggesting that psychotherapy may be helpful. And we see that psychotherapy was associated with reduction in depressive symptomatology and greater likelihood of remission. We're seeing that individuals who received CBT in addition to antidepressant versus usual care had high remission rates and higher response rates at 6 months. As a matter of fact, addition of CBT doubled the response and remission rates at 6 months. So this is something that is very similar in terms of quality of response. Whether we add CBT or add medication, there's not a huge difference in the outcome. So we should avail ourselves of CBT if it's available, because it can make a remarkable difference in our patients' lives. Furthermore, there is more recent evidence suggesting that certain forms of so-called specialized CBT, so in this case, this is rumination-focused CBT, may be of particular benefit to our patients. Why rumination-focused? Because rumination, although it's not a DSM-5 criterion for major depressive disorder, has certain central role in mediating other depressive symptoms. So having presence of ruminations is associated with significantly more negative manifestations of depression, severity of depression, functional impairment, difficulty with sleep, more irritability and anger, greater cognitive impairment. But presence of rumination is also associated with reduced positive markers of mood. So less ability to enjoy life, motivation, enthusiasm in individuals who tend to ruminate. So let us see how this CBT focused on rumination might be helpful to our patients. Well, these are data from two separate studies. The first one indicates that if patient did not respond to an antidepressant and we added CBT, 68 weeks later, they have double the likelihood of remission compared to community treatment. How about if they avail themselves of rumination-focused CBT? So within 26 weeks, roughly 6 months, remission rate associated with addition of rumination-focused CBT to antidepressant treatment was associated with 62% remission rate. So within 6 months, 62%. This is really remarkable outcome. It is approximately threefold greater than scenario where our patients remained on antidepressants and had treatment as usual in the community. So definitely addition of CBT, other forms of psychotherapy, possibly rumination-focused psychotherapy, can be a very effective intervention. Some other augmentation strategy utilized in STAR-D, adding lithium versus T3, thyroid supplementation. We're finding that they are approximately equally successful, and they can increase the likelihood of remission, but roughly 30 to 40%. Some of the other augmentation strategies included L-methylfolate and S-adenosyl methionine. And we're finding that addition of 15 milligrams a day of L-methylfolate as opposed to 7.5 milligram a day, which was ineffective dose, literally doubled response rate. Furthermore, addition of S-adenosyl methionine to an antidepressant also doubled and tripled response and remission rate in patients previously treated with antidepressants. So combination of antidepressant plus SAMI was associated with double to triple response and remission rate compared to individuals who received placebo with their antidepressant. If we look at overall data about lithium augmentation in major depressive disorder, we see that lithium augmentation in this large meta-analysis is associated with approximately threefold greater likelihood of successful treatment. L-methylfolate is helpful, but there are some indicators where L-methylfolate can be particularly helpful. So in addition to doing MTHFR genetic testing and identifying patients who are homozygous for T type of the MTHFR gene. So homozygous patients are at greater risk of non-responding to antidepressants, and L-methylfolate may be helpful. But in addition to genetic testing, there are some other indicators of favorable response to addition of L-methylfolate, and they include obesity. So if our patients have a BMI above 30, if they have higher inflammation, so CRP above 3, if they have higher leptin levels, all of those are indicators. So if there is abnormal inflammatory signaling, obesity, or lower conversion of dietary folate to L-methylfolate. In all these instances, augmentation with L-methylfolate may be helpful to our patients. Now, there are some newer strategies to either accelerate or augment antidepressants. One of them includes creatine. What is the whole story with creatine? Some of the biological studies of major depressive disorder have indicated that there is disturbance in bioenergetics. Creatine, converted to phosphocreatine, can enhance mitochondrial function and synthesis of ATP. So it may replenish energy supply, so to say. And we see that indeed augmentation with creatine was much more successful than patients who have received placebo in addition to an antidepressant in creating treatment response. Omega-3 amino acids, and this is a 1,200 milligram a day combination of EPA, DHA, and other omega-3 amino acids, was also associated with somewhat greater improvement. But particularly interesting is the study where scopolamine was utilized. So utilization of scopolamine, this is a milligram a day, was associated not only with accelerated response in treatment of major depressive disorder, it was associated with significantly increased response, but particularly remission rate. So at 7-week, remission rate was more than double when scopolamine, an antimuscarinic agent, was added. An age-old question, are 2 antidepressants better than 1? So first we're looking at a study conducted by Pierre Blier. This is a rather small study. You can see that ends are between 25 and 30. And here it appears that combination of antidepressants, so fluoxetine and mirtazapine, venlafaxine and mirtazapine, and bupropion and mirtazapine, was more successful than SSRI alone. And this is from the point of initiation of treatment. Combination appears to be better, except if we look at the study which included higher doses of all these agents. And if you will see that numbers of patients in each arm are approximately 8 to 9 times greater. What we're finding out is that using monotherapy of escitalopram was equally effective as combination of bupropion and escitalopram, equally effective as combination of venlafaxine and mirtazapine at 12 weeks and 7 months. So here we really didn't find a difference in this large study that actually utilized higher doses of all these agents. We really did not see a difference between an SSRI alone versus combined treatment. So let us see how all that may reflect on Lucy's predicament. She has had 3 previous depressive episodes and then again an indicator of resistance, including an episode of baby blues, so she may have had postpartum depression. Her early episodes did respond to a combination of an SSRI and psychotherapy, so psychotherapy was tried. Unfortunately, due to emergence of sexual side effects and weight gain, Lucy tended to discontinue her antidepressant treatment prematurely. She's currently ruminating about her weight gain and the risk of losing her job. So there is a chronic stress, there are ruminations. And she's also concerned that unless she can get it together, her husband may divorce her. You've seen that there has been ongoing marital discord. In addition to that, some alcohol use, a couple of glasses of wine nightly, not to be taken as precise measure. There could have been more than a couple of glasses. And her PHQ-9, which is 21, indicating severe depression. She had no family history of bipolar disorder, so misdiagnosis is not an explanation for lack of efficacy of her treatment. What can be done now? As a reminder, STAR-D did not include second-generation antipsychotics. So might addition of a second-generation antipsychotic make a difference in Lucy's predicament? And here we indeed see that olanzapine, risperidone, quetiapine, and aripiprazole, there are other agents that have been studied since in major depressive disorders, so this is a little bit older analysis, they added substantially. So if we were to use any second-generation antipsychotic, and as you can see, there are meaningful differences among these agents, but if we were to use any antipsychotic, it would, second-generation antipsychotic, as augmentation to antidepressant, it increases the likelihood of a remission by about 70%. So this is very, very likelihood of response by 70% and doubles the likelihood of remission. So it's a very meaningful difference. Yet another meta-analysis looking at a variety of agents utilized, I will point out that olanzapine fluoxetine has not been studied in patients who have had inadequate or incomplete response. It has been studied in treatment-resistant patients. So these are patients who have failed two legitimate, adequate trials of antidepressant. So it's a slightly different category of depressed patients. But be it as it may, the medicines that have demonstrated efficacy are aripiprazole, quetiapine, especially higher doses, and brexpiprazole. These medications added to antidepressants would be helpful. Olanzapine fluoxetine was helpful, but again, this is a more severe category of patients. This is patients suffering from treatment-resistant depression. So we see that we have only a handful of agents that have empirical proof of efficacy. Therefore, we are not to think that if our patient is not responding to antidepressant, it doesn't really matter which second-generation agent is added. That is an inaccurate statement. Some of them do help, some of them don't. So we always have to look at the flip side of the coin. If our patient is benefiting from this medicine, what is the long-term safety? Because odds are, when we use an adjunctive treatment for MDD, that this is something that will go on for an extended period of time. And what we're finding out is that some categories of adverse reactions have more negative impact on treatment adherence than others. So presence of EPS, agitation, tremors, restlessness, jitteriness, insomnia are all associated with 43% reduction of complete adherence. So they're very troublesome adverse reactions. And we have to consider them when making our treatment choice. And the second place are agents that are associated with metabolic disturbances, so changes in glucose levels, weight gain. These are likely to reduce treatment adherence by 36%. And then prolactin elevation, endocrine disturbances, sexual dysfunction associated with these agents is in the third place. It reduces treatment adherence by 31%. So it's a matter of balance, not only what is the efficacy of the medicine, but also what kind of adverse reaction burden will come with it. It is important to keep this balance when making a choice of an antidepressant. We spoke about some of the interventions that will have efficacy in treatment-resistant depression. This is one of the more recently approved agents. We're talking about nasal esketamine. It has established efficacy in 4-week study where doses of 56 and 84 milligrams were administered twice a week for a period of 4 weeks. The big question is this a good long-term strategy? So after early phases, initiation phase and optimization phase, which altogether lasted approximately 16 weeks, there was a long-term continuation treatment. How did patients fare long-term? And here is a short summary of these outcomes. So we're comparing patients who have been stabilized on esketamine and have achieved remission. As stable remitters, they were receiving esketamine once every 2 weeks in subsequent months. Administration of esketamine in addition to antidepressant versus antidepressant plus placebo. was associated with a 51% reduction in risk of relapse. So again, adding esketamine versus placebo to an antidepressant in the long run cut down the risk of relapse by 51%. How about patients who were stable responders? So they were doing better with esketamine, but they were not all the way well. Their regimen was a little bit different. They were receiving esketamine once a week in the long run. And we're seeing that in these a little bit more brittle patients who received esketamine more frequently, there was 70% reduction in relapse risk if esketamine was added to an antidepressant versus placebo added to an antidepressant. And then we see a couple of other relatively standard treatment strategies for treatment-resistant depression, TMS versus ECT. We see that ECT is associated with higher odds of achieving response than TMS. And there is some difference indicating that TMS may be a little bit safer and better tolerated. But both of those strategies can be helpful to our patients. Finally, collaborative care. As we have indicated, major depressive disorder is not only a psychiatric illness, it is a bona fide mind-body disorder. And therefore, what goes on in the body, if our patient has metabolic or cardiometabolic derangement or chronic inflammatory illness, it can significantly impact the outcome in treatment of major depressive disorder. Therefore, appropriate treatment is a team effort that includes other medical professionals. It is a good idea to have evidence-based treatment, to follow guidelines, to have established protocols for treatment of major depressive disorder. So it's not a haphazard choice. Indeed, scheduled follow-ups, not call me if things go wrong, but let us check in to make sure that indeed you're continuing to enjoy benefits and minimal adverse reactions, and that the balance continues to be favorable, because if not, that may need to lead to treatment adherence and relapse. And finally, if there are multiple professionals involved in treating major depressive disorder, it is good that they communicate, because it is very important information. If primary care physician has seen a patient in between the appointments with mental health professional, and indeed there has been a flare-up of inflammatory disease and worsening of depressive symptomatology, it is important to notify mental health professional of these changes. So what are some of the practical takeaways? Patients who have partial response, keep them on the medicine that they are on and consider appropriate augmentation and combination strategies. These strategies may include addition of another antidepressant, that's combination treatment, but also augmenting strategies where T3 or lithium are added, where second-generation antipsychotics are added. And it's not all, only a subgroup of second-generation agents actually have empirical evidence of utility. CBT is a very important and not often enough utilized strategy to improve depression outcomes. Also consider RTMS, consider ECT, and for treatment-resistant patients, in addition to these two neuromodulatory treatments, consider intranasal esketamine, which now has established efficacy and FDA approval. So let us now look at strategies that are utilized in particular scenarios. What if our patients are irritable or have mixed symptomatology? In this particular study, brexpiprazole, 2 or 3 milligrams, was added to an antidepressant. And we see that 6-week treatments of combination of antidepressant and brexpiprazole was associated with substantial reduction in SHIAD irritability score. At the end of 6 weeks, brexpiprazole was discontinued, antidepressant was continued, and we see an escalation in irritability, suggesting that brexpiprazole actually may have a specific role in assisting with irritability in our patients. And yet another study where a second-generation agent was used as monotherapy in individuals suffering from major depressive disorder with mixed features. These mixed features most frequently included racing thoughts, pressured speech, decreased need for sleep. So again, these are not bipolar patients. They're MDD patients with mixed features. Lurasidone, average dose between 35 and 40 milligrams, was utilized to treat this patient group with very positive outcome. Use of Lurasidone as monotherapy in these patients was associated with substantial reduction in their depression scores on Montgomery-Åsberg depression rating scale, with a remarkable effect size of 0.8. So Lucy was switched from an SSRI to an SNRI. 6 weeks later, she reported some improvement in anxiety, irritability, and energy, but indicated that her sleep is still awful. She has low motivation, difficulties focusing at work. So sleep, cognitive issues, and anhedonia, low motivation are still there. PHQ-9 is improved. It's now 16. It was above 20. So she still has marked depression. After a brief discussion, decision was made to continue with her SNRI and add a second-generation antipsychotic. A month later, Lucy's seen many improvements. She's sleeping better, has an easier time initiating, completing her work, and her PHQ-9 is now 12, so barely clinical. Are there some specific strategies that can help with fatigue, anhedonia, sleep disturbance, social dysfunction, and psychomotor and cognitive impairment? Well, here some insights from recent neurobiological studies may help us. Namely, there is a disturbance in the function of large functional network in the context of major depressive disorder. And these large functional network include sensory motor network. Sensory motor network not only includes parts of striatum and thalamus, but also precentral, post-central gyri, as well as premotor cortices. So indeed, a function of sensory motor network has to do with possibly emotional reactivity, sensory acuity in our patients, but also psychomotor functioning, both agitation and retardation. In addition to that, default mode network, and this includes midline structures in the brain, such as ventromedial prefrontal cortex, dorsomedial prefrontal cortex, posterior cingulate. Aberrant connectivity of these brain areas, either with salience network or cognitive executive network, is associated with cognitive problems in depression, with rumination in depression. And then finally, salience network, which includes insula and anterior cingulate, along with subcortical areas such as thalamus and striatum. Salience network provides meaning to changes in sensory inputs in the brain. It also has been implicated in depression. So we see that all these networks are innervated by serotonin and dopamine. So increase in dopamine translates into increased activity in sensory motor network and decreased activity in default mode network. Well, serotonin has buffering effect on sensory motor network, increased activity in default mode network. So it's not a matter of adding dopamine, taking serotonin, it's a matter of establishing appropriate balance. And furthermore, we see that there are very complex regulatory groups regulatory interactions when it comes to interactions between monoamine transmission. So serotonin has local regulatory mechanisms. Too much serotonin in dorsal nuclear raphe will activate serotonin 1A receptors and reduce serotonin synthesis and firing rate. Activation of serotonin 2B receptors, but too much serotonin on GABA interneuron would also suppress firing rate of nuclear neurons. So this is a local regulation, but we're also finding that there is a distal regulation because serotonin is released in medial prefrontal cortex, where it interacts with a number of its receptors on GABA interneurons and pyramidal neurons. Balance of serotonin activation of GABA and pyramidal interneurons reflects the output for prefrontal cortex, and since medial prefrontal cortex also regulates the function of brainstem nuclei, ventral tegmental area, dopamine nucleus, locus coeruleus, norepinephrine nucleus, and also dorsal and medial nuclei raphe, serotonin nuclei. If the output from medial prefrontal cortex is off, it can indirectly influence monoamine release. So there are local regulatory loops and also distant regulatory loops. All of them are influenced both by our antidepressant and by our augmentation strategies. So let's look at some take-home messages. This is data, again, that comes from STAR-D. And what we're seeing is that individuals who had appropriate energy levels tended to do well. 43% of them were remitters in STAR-D study. But on the other hand, if they had more pronounced fatigue, so higher fatigue scores on item 14 of quick inventory of depressive symptoms, their likelihood of achieving remission was cut in half. So remission with SSRI very much influenced by fatigue levels. Are there strategies that can be more effective? And here we're seeing that medicine that modulates catecholamines, bupropion in this case, is significantly more effective than an SSRI when it comes to improvement in fatigue and sleepiness. As a matter of fact, SSRI was less effective than placebo in helping with sleepiness. And again, use of norepinephrine dopamine modulating agents substantially reduced sleepiness in depressed patients. So catecholamines help with fatigue and sleepiness. How about psychomotor retardation? Again, based on the analysis, this is something that would involve the sensory motor cortex. And if you remember, catecholamines increase its activity. And here we see that SNRI venlafaxine was much more effective than escitalopram. Again, serotonin input into sensory motor network decreases its activity. So we see that substantially greater improvement was associated with dual-acting agent. How about cognition? A multimodal agent such as vortioxetine seemed to benefit cognition as measured with symbol substitution rate. So digit symbol substitution test or task is associated with mental fluency, processing speed, but also working memory and executive function. And we're seeing that multimodal agent was associated with significant improvement in cognition as opposed to tricyclic and SSRIs, which actually had a negative impact. All the rest of the agents were no different from each other. Multimodal agent is the only one that separated in its positive effect on cognition. And in a separate study from North Carolina, Tom Galtieri was the author of this study. We're finding that use of bupropion, again, a catecholamine modulating agent, was associated with improvement in cognition, where bupropion-treated agents are now similar to healthy control, which was not the case with individuals treated with SSRI, where there was minimal positive improvement in function. As a matter of fact, substantially lower than healthy individuals' controls. We've mentioned that anhedonia is another problematic symptom of depression. Are there strategies that can help with anhedonia? So utilizing a couple of different instruments. One is called SHAPS, abbreviation from Snaith-Hamilton Pleasure Scale. The other is an item on mood and anxiety symptom questionnaire. We're again seeing that medications that indirectly increase catecholamines, such as vortioxetine, also bupropion, are associated with greater improvement in anhedonia. Augmenting is medicine that enhances melatonin signaling, but also blocks serotonin 2C signaling. potentially indirectly boosting dopamine. And again, we see improvement in anhedonia scores. So multimodal agents and catecholamine modulating agents tend to be more helpful in treating symptoms of anhedonia. We also mentioned social adaptation and social functioning. And what we're finding out is that medicines that modulate catecholamines, primarily norepinephrine, can have beneficial impact on social functioning. So in a study that compared an NRI, reboxetine, norepinephrine reuptake inhibiting agent, with SSRI and placebo, found significantly greater improvement in scale that is used to measure social adaptation. And when it comes to individuals who were in remission, utilization of NRI reboxetine was associated with several-fold higher improvement in social functioning in remitted patient. And again, a comparison of milnacipran, an agent that in addition to serotonin, primarily modulates noradrenaline versus an SSRI paroxetine. Two things: utilization of agents that increases norepinephrine was associated with substantial improvement in retardation score, and at the same time, significant improvement in social functioning. So when it comes to social functioning, agents that boost norepinephrine may provide additional benefits. So as practical takeaways, not all antidepressants are made equal when it comes to specific domains of antidepressant function. Medicines that modulate catecholamines may have an advantage in patients suffering from fatigue, somnolence, anhedonia, and impairment in their social functioning as well as cognition. So in conclusion, even patients who are responding to antidepressant still have problems with their functioning if they're not in remission. Troubled primary relationships, early life adversity, medical conditions, especially the ones associated with inflammation, obesity, chronic stress, delay of treatment, substance use, personality disorder, all can negatively impact response to antidepressant treatment. Recent studies indicate that partial responders are going to benefit more from augmentation rather than switching. And antidepressants that modulate catecholamines might provide additional benefits together with multimodal antidepressants in patients who suffer from residual fatigue, somnolence, anhedonia, cognitive impairment, and social dysfunction. Thank you very much for your kind attention. I hope that this discussion will benefit you and your endeavor in treating major depressive disorder in your patients. Thank you.